Hello and welcome to this video. In this video we're going to talk about abdominal pain. As usual, don't forget to like and subscribe to this channel for more content that supports me and allows me to bring more content. And don't forget to leave a comment below for any queries or any more information you would like to know. So let's get straight onto it. In this video we're going to cover abdominal pain, as you can see with this illustration. This is quite a common presentation in OSCE scenarios, so let's get straight onto it. So with any type of pain, you have to use the acronym which we use always in this setting, which is Socrates. So the site obviously is the abdomen. So site, just say stomach. Onset. Now you want to know if this abdominal pain was sudden. So obviously it being sudden, you will be more cautious. Is it like a chronic type of abdominal pain, or let's say is it like gradual type pain? So gradual onset. It's very important you know exactly where you want to classify this type of pain. Okay, so C stands for character. So what I ask if is like a dull ache, is like a sharp burning sensation, okay, that can give you a little bit an idea what the type of pain would be like. Radiation, does it go from your radiate, does it radiate anyway? And depending on the type of pain, some will radiate from the stomach to the back, to the left, to the umbilical region. So you need to start having an idea of how this pain may evolve itself. Now into the associated symptoms, I'm going to go a bit in quite details, but you don't need to ask all these questions. You need to layer it or the way you think is great. So I'm just going to give you like a set of questions I normally ask when it comes to abdominal pain. So I start with like any bloating. Okay, this is actually quite important if you're thinking IBS or IBD, or a female that presents with non-specific symptoms. Any change in bowel habits. So let's just say change in bowel habits. Obviously, this allows you to have an idea if they don't, if they have a huge change in your habits. Some people go from once a day to 5 a day, 10 a day. So you start thinking, hold on, could this be a scenario of IBD? And obviously, you want to ask if they change in the color or in stool appearance. Okay, so if the stool appear different, like more pale or more darker, obviously if she's a female using iron tablet, definitely the stools will be more darker, which is kind of like a common indication for iron tablets. So if the patient has like some constipation type symptoms, you want to ask them, are they straining? Okay, so this is just me being very detailed. You don't have to ask all this question. You just have to know according to the patient. Okay, don't treat the findings, but layer it according to the patients. Okay, so another thing I ask is the symptoms worse with eating. Okay, so you want to know is this from some symptoms of cholecystitis or something. Okay, and obviously you want to go for the classic questions, weight loss or fever. And you can ask more questions like loss of appetite. Just be quite open with this with the associated side symptoms questions. Okay, as I said, you don't need to ask all these questions. So timing, is it there all the time? So just say always. Or we can say constant pain, or is he on and off? So this gives you an idea of how frequent they have in this episode. Now we are running a little bit of space. Okay, so does anything make it better or better or worse actually? So obviously if the patient say that it's constant and is getting worse, you need to be a little bit worried. Okay. And severity, I normally say 1 out of 10, 10 being the worst. You kind of have an idea of where you want to classify the pain. So after you finish your Socrates, you've explored the pain or the symptoms of pain. You want to have an idea in your mind, obviously the red flags. Now, you don't need to mention it to anyone, but I like to classify my history taking according to the red flags. Actually, before I actually take a history, when I'm writing down my, the questionnaire or the question I'm going to ask, I actually write down the red flags. Okay. Now, with abdominal pain, it clashes with so many things, so you have to be quite sensible. However, stuff like hematemesis, like vomiting of blood. Let's see if I can actually write this. Hematemesis, which is vomiting of blood, is quite a red flag. Is there like a upper GI bleed going on? Okay, and obviously your appendicitis is a common one for abdominal pain. Appendicitis. Sorry, I need to think before I write, because I just write rubbish. Obviously, for female or gynae, ectopic pregnancy. Obviously, we'll discuss a little bit where this pain would present, but this is kind of like your medical emergencies. What am I? Oh, obviously, your triple A's are important. So, aortic aneurysm. I have no idea what it stands for, but your patient would present with non-specific symptoms, mainly hypotension. That will be your examination finding. Obviously, being severely pale, just not looking well, if I have to say the truth. And your patient will present with severe pain if they have like a bowel obstruction. So that's also quite an important one to keep in mind. And obviously, if you're suspecting bowel obstruction, you need to ask them: are they how do you say in a simple way? Are they releasing gas, or are they farting? You have to be quite open about these questions. So this is kind of like the main red flags I tend to prepare myself before getting to the station. And I laid down my history taking around these red flags. Now let's go to the common causes of abdominal pain. A common cause that I see oftentimes in primary care is obviously, I would say, IBS type symptoms. So kind of like non-specific type symptoms. So flatulence, the presentation will be flatulence, bloatness, very common. Some will present with diarrhea also. I hope you can rewrite it that way. Or constipation. Let's actually put this slash here, constipation. Because patients that present with IBS will kind of like have either diarrhea or constipation. And these symptoms are generally worse with stress. So worse with stress. Very important to ask some specific question about, are they stressed at work, relationship, and obviously cramping, very common presentation with IBS. Then you can do some extra examination. You can do like a stool test, what's the stool test? It doesn't come to my mind. Fecal calprotectin, that's it. Fecal calprotectin, that's a good test to check for IBS. And another one that you could check is maybe celiac, common presentation. Celiac, that's it. So they may present with diarrhea. Again, these are all non-specific symptoms. Diarrhea. I know I'm writing it wrong. I just can't spell diarrhea. Then steatorrhea. It's so hard to write this stuff. Steatorrhea. Some will present with anemia type symptoms. So obviously you do the full blood count, and you will kind of like have to test for celiac with the antibody test. And obviously abdominal discomfort. Okay, again, these are just common causes. You know, a patient will present with other stuff. And obviously you will have your IBD. So similar to IBS, which is inflammatory bowel syndrome. No, irritable bowel syndrome. IBD is inflammatory bowel disease. So do we have obviously blood or mucus in the stools? That could be obviously being blood mostly for ulcerative colitis, but I don't want to go into much details about that. They may have obviously abdominal pain, quite severe abdominal pain. Some of them may have mild abdominal pain. Some patient would just come with change in bowel habits, and that's the only symptom, change in bowel habits. Okay, I've seen a patient just come with just that, no pain, no pain at all. What else? Then some of them will present with weight loss. So again, non-specific type symptoms, but you just have to be sensitive. Another common cause in primary care is diarrhea. So again, I have to write the name, or just gastroenteritis. This is like a stomach bug thing, and they will present again with acute diarrhea. Sometimes that lasting a couple of days, even a week. If the diarrhea lasts more than 2 weeks, you can do a stool culture. But obviously, very unlikely a case scenario like that will come in the OSCE. And some of them will come also with nausea and vomiting. In that case, you want to ask about travel history. Obviously, now with COVID, that is not really pertinent, but some people still do travel even though with COVID. Okay. And one last one I think you should keep in mind, which is necessary. It's not necessarily a common presentation, but just to keep in mind is presentation of colon cancer. So a patient will present with blood in stool. Actually, this can actually come up in the OSCE. So as soon as there's blood in the stool, you need to think either IBS, IBD, and malignancy really, or maybe diverticulosis if they are elderly. But those are the main things I would think if there's blood in the stool. But depending on the type of case study that they present to you. Again, weight loss. Obviously, being unexplained weight loss. Okay, and if you do a full blood count or full blood work, they will have anemia, especially if they are elderly over the age of 60 and they present with these symptoms. Yeah, it's probably some form of colon cancer, or at least you should refer them for a 2 weeks wait. So now we are going to get into the nitty-gritty of it. So this is very important when you're taking a good history. You need to be able to have an idea where certain presentation occur with patients. Okay, so we have got like an abdominal pain location. It's like where the pain is. So we have I divided into 4 places. Obviously, being the left upper quadrant. Okay, left lower quadrant. The right lower quadrant, and the right upper quadrant. And this being the, let's just say this being the epigastric region. Then we have here the suprapubic region or area or zone or location. And I think that's kind of like the thing you should know. especially when you're examining the patient, doing examination. Okay, so let's start with the epigastric region. So let's just move this a little bit. So the presentation in the epigastric region, patient will say, "Oh, I've got symptoms of a heartburn." So you kind of know it could be reflux, or could be maybe hiatus hernia. Obviously, you're not gonna do that by examination, but you can suspect that. It could be a stomach ulcer or a duodenal ulcer. So just say ulcer. So keep that in mind. A patient may have an ulcer. Okay. So going to the left upper quadrant again is a stomach ulcer. Okay, or signs of symptoms of dyspepsia. Dyspepsia. So you probably want to do some further investigation, like a stool test, H. pylori, very easy. Oh, I also forgot the umbilical region. Sorry, umbilical region, whatever it is. Right. Actually, let's talk about the umbilical region. Normally, you don't find anything other than maybe another hernia or early appendicitis. Appendicitis. Which obviously will radiate to eventually to the right lower quadrant. Okay, then let's go down to the left lower quadrant. Now this is way more specific for people that have like I would say diverticular disease. Vertical disease. This is actually quite common in women, elderly women. Just like a risk factor to keep in mind for yourself. Constipation. So when you examine them, they'll be presented with, constipation type symptoms. When you have a feel, you actually feel the stool. This is quite important, which is our red flag. We talked about this, ectopic pregnancy. Nancy, and the lady will be in severe pain. And in the suprapubic region, you have things like UTI type symptoms. So it's not necessarily abdominal pain, but it's these abdominal pain actually. So let's just say put a small arrow here, UTI. Yep. Now let's go to the other side, starting from the left lower quadrant. The things you should be aware of specifically for the left lower quadrant is obviously your appendicitis, again constipation, very common. And moving up to your right upper quadrant, we have the cholecystitis. Oh my god, cystitis. I just can't spell today, but you guys won't know what I mean. And or gallstone. Those are your main things you should be worried about. I know it's quite confusional, but just for you to have an idea of the locations of what you should be looking for in an abdominal pain. Okay, so let's talk a little bit about the treatment. So going to treatment, I'm not going to cover every single treatment, but I think you should know, even as a student, if a patient presents with constipation, which is quite common even in your primary care. The first thing you want to check is are they taking some codeine. If they're taking it, ask them to stop it, at least for the time being, and you want to give them some laxatives. This is quite common obviously with elderly, That could be your Movicol, your Senna, and so forth and so on. Okay, so if you get a constipation station, you're flying, man. You're flying. Another common one that, in contrast, you have your diarrhea, which I can spell. Diarrhea, something like this. Obviously, if it's less than 1 week, conservative treatment. You design conservative treatment. So you want to tell them drink plenty of fluid, small meals, keep yourself hydrated. Okay, but you can tell the patient they can take over the counter Imodium, or the name would be I think loperamide. I think it's about 2 milligram. Don't quote me on that, but it should be that. If it's more than 2 weeks, I would generally do like a stool culture. And that is it, really. That is the main treatment that you can follow through with simple scenarios. I'm not going to go through the whole thing, but those are the simple ones that can occur in an OSCE scenario. Anyway, we diverted a little bit from the OSCE scenarios itself. Anyway, after you've done Socrates, and you will know a little bit what is going on, you have to obviously ask about past medical history. Very important. You want to ask the family history, and family history of bowel cancer, bowel disease, IBD, IBS, you name it. Okay. Ask about drug history, any medication they're taking regularly. Are they taking statins and stuff like that? Any allergies? You want to ask about their social history. Do they drink loads and loads of alcohol? Do they purge? I don't know, anything of that sense. And don't forget to ice your patients. Idea, concerns, and expectations. This will give you a little bit of an idea how the patients feel, and if they need to be seen straight away. And at this point, you summarize your finding, and you should be good to go. And they'll probably ask you, what are you thinking? And hopefully, going back to the abdominal pain location, you can have an idea where the pain is coming from, and you can take it from there. And that's it for me in this video. I hope you guys enjoyed this video. Don't forget to like and subscribe to my channel, and leave a comment below with if you want a video suggestion or you have a comment. And see you guys in the next one. Goodbye.